Thank you, Dr. Masoud, and thank you all for coming on a Friday. I'll try to make it worth your time, inshallah. Now, the topic, unfortunately, is too big to be discussed in detail in one session, so I had to change things. Instead of focusing on the academic sort of the topic, I will focus more on the practical and pragmatic side. And you don't need to take any pictures. You can get the whole lecture as a PDF by talking to Mr. Tamer or texting me at the end. I will put my WhatsApp. Just send me that you want the lecture. You will get it, the entire thing. Now, the way I built this is this will be a source for you to review the topic after you go. I noted that a lot of the attendees might not be surgeons, so this lecture is based for everyone. You can even send it to any one of your colleagues. You're welcome to do so. So I have no disclosures. However, I must mention that I did use the help of AI in making some of the slides. So this is something for you to be aware. Now, for the sources, there are multiple sources to talk about the topic, but none of them, not a single one of them, is like exceptional. All of these sources have a lot of limitations. So when you read each one of these sources, just keep in mind that, keep this in your mind, that none of these sources are excellent for the topic. However, I try to make the whole things as organized as possible, as easy as possible, for you to be able to actually deliver this service to your patients. Now, constipation and surgery, we have to understand that surgery has very limited role in treating constipation patients. But there are some important topics that we must not miss as surgeons, and you must not miss it as a gastroenterologist. If you have one of these things, you do need to refer it to your surgical colleagues. Nonetheless, mostly constipation, the treatment is non-surgical. Now, so where do we start? So let's talk about classification. If you go out to the literature, you will notice multiple classifications exist. Some of them, for example, depend on idiopathic versus simple versus chronic. It doesn't matter what classification you find, as long as you have a classification in your mind and that you follow it. That's the most important thing. Be consistent and be organized. But there are some useful classification like primary and secondary constipation. Primary being the one that we see every day and all of us have encountered. Secondary are the things that you do not want to miss because you need to do something besides giving just laxative. There are other approaches to it. Then we'll talk about some other useful classification that you need to be aware of, like for example, the ROM4 criteria. Now, keep in mind that ROM4 is not to diagnose constipation, but rather to differentiate the different subsets of constipation. Like for example, the IBS with constipation. And out of these, this is the most common. And there is also the functional constipation, and there are also opioid and other modalities. Now, is there any role to treat the patient first who comes with constipation before we investigate? And actually there is, and this is what I wanted to show you. Not every patient who comes to us in clinic complaining of constipation will need a barrage of investigations, a barrage of tests. A lot of them you can attempt by giving some laxatives first and see how they improve and how they respond. Then you can consider investigations. However, there are some exceptions. There are some patients that we need to investigate upfront from the initial presentation. And I will explain to you later what these patients are. But all in all, you can start them on laxative, and this is what I call investigation by treatment. You give them simple treatment, and if they respond, then you are 95% sure that this is functional or idiopathic constipation, and no need to worry about it anymore. This is just to show you the type of what the guidelines are suggesting, what medications are they talking about, and how we do it. So again, these are the medications to show you with the classification, which one you should start. As Dr. Ghassan before me beautifully mentioned, that we should start by fibers initially, but there are other stepwise approach that we can follow as well. I'm sorry. However, if we encountered any patient that we should investigate with a colonoscopy, these are the patients that we must not miss. And I will keep this type of patient until the end of my lecture, so I don't miss you in the middle. But keep in mind, these are the patients you really want to investigate and make sure you do not miss. The rest, we can talk about it. For example, the whole list of these tests, even if you fail to spot a patient who will need them, and you spent a year or two treating the patient before you investigate it, limited harm will happen to the patient compared to a patient who needed a colonoscopy in the upfront and that was missed. So if there is one investigation I want you all to be aware of, it's colonoscopy, please. Sorry. However, there are other tests, like for example, anal manometry. And this test, we can investigate pelvic floor dyssynergia, we can investigate patient with hypertonic anal sphincter, and a lot of other defecation disorders. This is the what we call the fluoroscopic defecography. Now, for you to be aware, this is falling out of favor in a lot of the newer centers. A lot of the newer radiologists are out frankly refusing to do it, and instead they are guiding you to do an MRI defecogram. Nonetheless, the most important two things about this test is, first of all, it's cheap. It's very cheap to do this. The other thing, this is actually done in the normal physiological position, where the patient is sitting like what they usually do during defecation. MRI defecography, on the other hand, while it shows us the soft tissues, and it shows us real time how the soft tissue move, it can show us other stuff like sigmoidocele, for example, enterocele or rectocele, better than what the fluoroscopy does. It unfortunately is done on the side position. It's not a physiological position to defecate. That's why a lot of the patient will have false positive finding of inability to defecate simply because they are not in the correct position. Now, there are some MRI machines that is done in the upright position, but they are very rare. For example, the entirety of the UK where I was trained, no machine like that exists. So be aware, if you request an MRI defecography, it's going to be done in an abnormal position. Now, this is what we call the colonic transit study. This is something we try to use to differentiate between just simply functional constipation or defecation disorder compared to slow transit constipation. Sorry. Right. So why I wanted to show you this slide is just to show you that unfortunately the literature is very vague when it comes to talking about what constipation we should treat with surgery and when. And actually the thing that they say is, even if you develop a constipation clinic, a clinic just dedicated for constipation in the hospital, and you start receiving patients specifically sent to that clinic, only 1 to 3% of these patients will actually need the surgery, will actually need some form of surgical intervention. So this is quite rare. Sorry. So the other item I wanted to say from the guidelines as well, that the first thing we must ask ourselves when, as surgeons, when we receive patients for constipation to consider surgery is, did these patients really exhaust their medical treatment? And this is the first thing we should consider, actually giving them the second line of medical treatment, discussing it with your colleagues again. Try to maximize medical therapy before we can consider. Okay. However, there are some suggestive guidelines and algorithms, but these are very rare, extremely rare. This is the only one that I found that is not department specific or center specific. Talk about how to treat this type of patient. And as you can see, the idea is what they do is they try to go systematic. And this is the bottom line of it. Be systematic. It doesn't matter what guidelines you follow. It doesn't matter what system you follow. Just be systematic. Try to deal with the same people. Try to have the same gastroenterologist, the same surgeon, to be able to be consistent. Right. So now let's talk about when it actually becomes a surgical problem. Right. So we must always just remember that to understand when it becomes a surgical problem, you have to understand the pathology itself. So this slide is just designed to show you when you can consider that this patient can be a surgical. And the idea is you have to follow the entire pathway before then you deciding this patient needs a surgeon to be seen. Okay, I will not delve into it deeply because again, the idea is for you to be aware what's happening rather than to know exactly what's in every slide. So let's talk about disease-specific things. Let's talk about this slow transit constipation. This is basically that the colon is a bit slow. There is a delayed transit of the fecal material from the right to the left of the colon, reaching it to the rectum. So in this case, the patient would likely retain more of their markers after day 7. So this is something to be aware of, rather than functional constipation, rather than people who have pelvic floor issues and defecation problems. These patients, the markers will be all on the rectum, and the problem is actually evacuation. No, this is different. This is the transit itself is slow. Now, the treatment for such things is, first of all, to make sure that the small bowel is not the problem. And that's the benefit of finding it all in the colon. Why? Because even if you remove the whole colon and the small bowel has some slow transit, then you have failed the patient. The problem was never the colon. The problem was the entirety of the bowel, and that's a different pathology. Typically, you find this in psychiatric patients, in patients who have multiple comorbidities, and the treatment is a bit different. More importantly, we must understand: are they taking the laxatives truly? Are they responding? Have they reached to their optimal medical treatment? Now, if they end up coming to the surgeon, then the option we can consider is subtotal colectomy with an iliorectal anastomosis. Some people even go more aggressive, unfortunately, and they consider proctocolectomy with ileal pouch rectal anal anastomosis. I think both the American and the British guidelines are both saying that this is too much, this is aggressive, it shouldn't be considered. However, total colectomy with iliorectal is somewhat in the gray area. Nonetheless, no patient should undergo surgery except if you are absolutely sure it's not an obstructed outlet obstruction like pelvic floor dyssynergia, and that the patient did receive optimized medical treatment. Now, rectal intussusception, this actually related very well to the topic of Dr. Ghassan, because a lot of these patients are actually, this is the cause of the solitary rectal ulcer. So solitary rectal ulcer, which I will talk about in a minute as well, is actually a symptom rather than a disease by itself. A lot of them, this is what they are encountering. Rectal intussusception, meaning that the rectal prolapse is still internal. The problem with this disease is a lot of our colleagues will completely disregard it, saying no need for surgery, no need for intervention. And this is not always true. Sometimes these patients will still require surgery and intervention if they failed medical treatment. And the form of surgery we can consider is just to fix the mesh if it's a female, and to fix the rectum and ensure that the patient is no longer telescoping within its own bowel, or to remove the excess bowel, like for example a sigmoidectomy, if the problem is truly a loopy long sigmoid. But again, I cannot emphasize enough, surgery is only when we have exhausted medical treatment. Inshallah. So rectocele, it's a different disease, and that's again, it's one of the diseases that's hugely misunderstood, and I will influence you again to think of it as a symptom rather than a disease by itself. And the reason is, if you try to fix it alone without fixing the pelvic floor problem, again you will have a failure, again you will have non-improvement of the patient's symptoms. So only consider treating it if you have treated the pelvic floor issues and the patient is still symptomatic, they are digitating, and the way to identify it or suspect it in the clinic, that the patient will tell you, I cannot defecate except when I put my finger into the vagina. They digitiate the vagina or the pelvic floor rather than digitiate the anus. This is hugely suggestive and almost diagnostic of rectocele. So pelvic floor dyssynergia, this is quite common, male and female alike. Obviously with females it's more diagnosed, but this is possibly misleading because they are the one who actually come to seek treatment for it, while usually the males refuse to come to the hospital. So we don't know for sure. Is this related more to the female age or it's a presentation bias? Nonetheless, the treatment, I will not go delve into it because it was beautifully explained by Dr. Ghassan when he talked about it, but the treatment is non-surgical. There is no surgery to fix this. The treatment is biofeedback, 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 okay? Even the Botox, it's useless. It is one of the useless operations in this type of patient. Salivary rectal ulcer, again, beautifully explained by Dr. Ghassan. But most importantly, the only one thing I will mention here is make sure that this is the correct diagnosis. Make sure you have an excellent GI histopathologist. Make sure that your biopsy is actually representative. If it doesn't make sense, if this patient is above 50, please consider an alternative diagnosis. Make sure you don't miss the serious things. Megacolon and megarectum, the only thing I want to add in this patient is be considerate that this patient might still need surgery. With megacolon, megarectum, it is caused by chronic constipation, yes, but they might sometimes need surgery to fix the anatomical problem. So adult onset Hirschsprung disease, this is another cause of chronic constipation that you might encounter in adults. Most importantly, you must take proper history. A lot of these patients, it's true they presented to you as an adult, but when you dig in the history, you find that they were struggling since they were children. Simply their symptoms wasn't serious enough to actually present to a pediatric surgeon before. And for them, they will need surgery. Next, anal fissures. Now, we all know anal fissure is a result of a constipation or an injury to the anal mucosa. But the importance of this is patients and some doctors always believe that this will cause constipation. In a way, it does, because patients are afraid to defecate. They are afraid to go to the toilet. So make sure you treat this very well. You give the patient good laxatives. You give them diltiazem or nifedipine cream. Please try to avoid the GTN creams. Patients are non-compliant on it because of the headache. And if you need it, you can even consider clinic-based Botox. Large hemorrhoids, again, I will explain to you that this is not the cause of a constipation. This is usually the result of it. The reason why I mentioned it, a lot of patients and some doctors, unfortunately, tell patients, your constipation is because of your hemorrhoid. Visit the surgeon, let them remove your hemorrhoid, your constipation will improve. This is not true. And if they do, and when they do actually remove the hemorrhoid, it's painful because they still have hard stool. We still haven't controlled the constipation. They're going to have post-operative difficult course. So please make sure you treat these patients very well before you send them to the surgeon to treat them. And this is the most important slide. These are the things that we cannot miss. We must try to find them from the initial presentation. These basically to make sure that we do not miss a colorectal cancer presenting as a constipation. Yes, I agree. Most colorectal cancer present as a diarrhea or anemia, but they can present also as constipation. Make sure that you're not missing a colorectal stricture, that the patient is not telling you, I feel a bulge in a certain part of my abdomen, I have to press on it to be able to defecate, or large polyps. Diverticular stricture were very common in the UK where I was trained. Luckily, we don't have them a lot here, but in the UK, like in every clinic, you will find one. And also make sure that this patient doesn't have an extrinsic pressure on it. So abdominal exam is essential in these patients. Yes, I am almost done, doctor. Sorry, So this is just to show you how the surgeon should think and what are the steps that we should keep in mind. This is just to show you that we need to be consistent. There is ways and there is a way to approach it. Identify the problem, make sure the optimal non-operative care has been exhausted. All of these things need to be considered. And this is the importance. It should not be a one-man show. It shouldn't be a one-doctor show. Effective treatment of constipation, especially complex constipation, should be a team management. Should be the gastroenterologist, the pelvic floor physiotherapist, the surgeon, all of them in one team. And this is my take-home messages. Basically, make sure that every patient will need a different approach. There is no one solution to fit all. Make sure that you go by these steps, you understand, you follow, you ensure that you don't jump to a surgery before you have done all of these bits, including working as a team, including doing an MDT. I cannot emphasize this enough. Please don't take a patient to OR before exhausting all of these steps. But however, to keep in mind, these type of patients are rare. You are more likely to encounter one every few years than you are to encounter, for example, a colorectal cancer or another pathology. Nonetheless, keep in mind and try to not to make an unnecessary operations for this type of patients. Feel free to get in touch if you want. If you wanted this lecture, I'll be happy to send it to you. And if you wanted to discuss a complex case or a patient of sort, please feel free to do so. Thank you.